Welcome. My name is Tony O'Brien and I'm a palliative medicine physician. In the context of the escalating coronavirus pandemic, I was asked to prepare some symptom control guidelines for those who will be caring for imminently dying patients. A few words of warning at the outset. The information contained in this presentation represents my own personal views, and the guidance is prepared to assist clinical decision-making by staff who are caring for imminently dying patients as a direct, inevitable and irreversible consequence of COVID-19 infection. For many drugs referenced in this presentation, the stated indications and route of delivery are off-label and in general are supported by clinical experience only. And therefore the decision to implement any of the guidance contained in this presentation and in any allied written material, in whole, in part or not at all, is solely at the discretion of the senior responsible clinician. In 2010, this paper was published focusing on the role of palliative care in a global pandemic situation. And we are advised to prepare with due regard to four distinct headings as represented on this slide: stuff, staff, space, and systems. And briefly, we need to ensure that we have an adequate supply of necessary medication and equipment to enable us to do our work safely and effectively, and this needs to be available across all healthcare settings, including community settings. We need to identify those staff with palliative care experience, and not just doctors and nurses, but also those with expertise in psychosocial care, bereavement care, social work, and pastoral care. In terms of infrastructure, we need to identify wards and other areas where large numbers of patients can receive end-of-life care. This will require us to maximize the use of all available space, including space that traditionally was not applied to clinical functions. In terms of systems, we need a triage system to identify those in need of specialist palliative care, even if recovery is still a possibility. And this will include those who are deemed suitable for ICU admission and also those who are not. We need an integrated triaging system across all hospitals, hospices and community settings, with a direct consultation support service for those working at remote sites. And for all inpatients, I believe it is helpful to have a documented ceiling of care and also to highlight if a patient has some form of advanced care directive. And throughout, we will be caring for three constituents: the patient, the family members, and of course, staff. By the term imminently dying, I mean those who are rapidly approaching end of life. The prognosis is limited to a few short hours or less in some circumstances, perhaps a few days, and the patient is likely to be unresponsive. The senior responsible clinician, either alone or in consultation with others, has determined that there is no further prospect of achieving reversibility, and there is now an exclusive focus on comfort. And once a diagnosis of dying is made, and it's a very important diagnosis to make, this must be documented in the healthcare record and rapidly disseminated to all relevant teams and services. This marks a very major change in focus and change in direction in terms of patient management. The diagnosis must also be shared sensitively with close family members as appropriate. Persons with COVID-19 infection who are approaching end of life will have come through one of two pathways. The first group, the larger group, will have followed a conservative pathway and will not have been offered ICU support and invasive ventilation. A second group, a minority perhaps, were those who were offered ventilatory support, and despite the best efforts and the use of maximal supportive therapy, those patients continue to deteriorate, and a point is reached when medical futility is identified and the patient switches to an end-of-life care situation. The diagnosis of dying in any circumstance is not easy. There is no one feature. There's no laboratory test or radiological diagnosis. Rather, we depend upon a constellation of clinical signs. We look at the trajectory and the evolution of the clinical course. We look at the patient's reliance and dependence and response to ventilatory and other supports. We look at the extent to which we're seeing or not seeing a meaningful and sustained response to these various supportive therapies. And this is all integrated, and of course we draw on our own clinical experience and intuition. We have good data to enable us predict when death is occurring, particularly in cancer patients. The extent to which this translates to COVID-19 patients is simply not known. When a person is approaching death, it's important that we take the opportunity to engage with the family. We need to prepare them, we need to support them, we need to empower them, and we need to educate them. They must be alert to the fact that death is imminent, and we can advise them of the physical changes they are likely to witness. Families in this situation require clear, consistent messaging with appropriate reassurances. It's often helpful to check their previous experiences of death and seek to establish what their expectations are. This is an opportunity also to correct any misunderstandings that they may have, and gives us the chance to explain our management strategy and our focus of care. Once a diagnosis of dying is made, it is helpful to review all of the current interventions. In general, it is entirely appropriate and strictly necessary to stop all other supportive and active therapies and interventions other than those absolutely required in order to achieve and maintain optimal symptom control and comfort. So, for example, in these situations, I recommend the discontinuation of intravenous fluids, antibiotics, subcutaneous heparin, insulin, enteral nutrition, and TPN. We should seek to remove oxygen masks and nasal prongs and ensure that a DNA order is signed and EWS discontinued. This is the time to formally stop all blood and radiological tests and to stop monitoring vital signs, including oxygen saturation, fluid balance, and so on. If a patient has an implanted cardiac defibrillator, this should be deactivated at this time. I recognize that these measures are difficult and challenging for many clinicians. We are now abandoning all efforts to save or prolong life. And the culture of the specific care environment in which we operate will impact on our thoughts, on our attitudes, and on our behaviours. In this instance, perhaps more than others, we are confronted directly by our own powerlessness. We are now shifting to an exclusive focus on comfort measures. If a patient's condition unexpectedly improves, these measures must be revised. Prescribing at the end of life is always anticipatory, and the correct dose of any medication is the lowest possible dose that achieves the desired effect. But there is wide variation in doses of drugs required. Hence, careful and regular review of each patient is essential as we adhere to the principle of individual titration. Breakthrough medication or as required medication must also be prescribed. And let me reassure colleagues that there is no evidence that the skilled use of appropriate medications in selected patients at the end of life, including opioid medications and other sedative medications, has any impact on the duration of an individual's life. When assessing patient comfort, we recognize that there is wide variation. Colleagues may disagree with colleagues or with other family members on the perceived comfort of an individual patient. This is a complex area. The patient is unable to voice an opinion. Sometimes we may project our own distress onto the patient. This is a time when staff and family members typically are hypervigilant, and we may interpret any movement, twitch or grimace as pain or distress. Equally, healthcare professionals may ignore observed signs of distress because of a lack of confidence in administering necessary medication at the end of life, or because of unjustified fear of causing or precipitating a death. Always we require a calm, reassuring and confident presence at the bedside. The objectives are clear. We need to keep the patient as pain-free and as comfortable as we possibly can. We must reassure the family that everything possible is being done to maintain patient comfort and dignity. This is an important element as we seek to reduce bereavement morbidity. But we need to set realistic expectations for ourselves, our colleagues and family members. We cannot take away the pain, distress and grief, but we can always support. And in part, our role in these situations is one of damage limitation. We can't undo the hurt, we can't take away the pain, but we do whatever we possibly can to support, to enable, to encourage. And family members will often have a whole range of questions at this time. They may ask, how long has my loved one got? Can he still hear? How will you know if he has pain, since he cannot speak? Is he dying of dehydration or starvation? He hasn't had anything to eat or drink for the last 12 hours or 24 hours. These are very important and very serious questions. They need to be taken seriously and answered appropriately. You will have your own way, your own style, but some of the responses I have found helpful over the years are as follows. When asked how long a patient has to live, I confirm that we cannot be certain. But if I feel somebody is imminently dying, I'm happy to confirm that the life expectancy is likely to be within a few hours or days at most. I then invite family members to say what it is they would like for their loved one, what it is they want, what it is they're hoping for. Another commonly heard question is, can he still hear? And again, the response is to acknowledge our uncertainty, but invite the family member to say something to the person who is dying. Tell them this is a good time, this is as good a time as any. If there's something you would like to say, why not do it now? And family may be concerned lest we fail to recognize that their loved one is in pain. They can be reassured that they will be watched very carefully for signs of distress. We can tell them we'll see it in their face, in their general demeanour, and reassure them that whatever medication is required is available to them. The issue of food and hydration at the end of life causes great distress to many family members. They are disturbed that their loved one is not continuing to receive some form of nutrition or hydration. And we can explain that at this time, all of the vital organs, including the heart and kidneys, are shutting down. The body cannot cope with excessive food or fluid at this time. Nature is taking care of everything. Medications are a necessary part of our management of the dying patient, and typically these patients will be unable to swallow, and hence we need to look at alternative routes of drug administration. In palliative care practice, we commonly use the continuous subcutaneous infusion route, supplemented as necessary by bolus subcutaneous injections. If the patient happens to be in a setting such as an ICU setting, where there may be greater familiarity with the intravenous route, then there is no particular reason to change. The transdermal route has very little application at this time of life, primarily because we don't have the flexibility in terms of dose selection, and we certainly don't have the responsiveness that we require. Another option to consider, particularly if somebody is in a setting where they don't have easy access to healthcare professionals and they require additional analgesia, is the intranasal route. And there are some intranasal preparations of the potent opioid, fentanyl, available, and they have application, particularly in this setting. I don't propose to go into any detailed advice regarding the use of syringe drivers. This is beyond the scope of this presentation. But just to note that normal saline is a reasonable choice of diluent in most circumstances, unless we're using cyclizine, in which case water for injection is preferred. We use opioids primarily in the management of pain and dyspnea. If the patient you're treating is opioid naive, then a starting dose of morphine, say 10 milligrams, delivered by continuous subcutaneous infusion over 24 hours is a reasonable starting point. As mentioned earlier, all these patients should also be charted for PRN medication as required medication, and an appropriate dose in this specific instance is 2.5 milligrams, which may be given every 2 to 4 hours as required. And if the patient survives longer than a 24-hour period, it will be helpful to collate the total amount of morphine administered the previous day, both by continuous infusion and also the PRN use, and that then becomes the baseline for selecting a dose in the infusion over the next 24 hours. The PRN dose is typically somewhere in the order of between a quarter and 1/6 of the baseline 24-hour dose. So what that looks like in practice is something like this. If we have a patient receiving morphine 10 milligrams over 24 hours, and we look and see that they have required 6 doses of 2.5 milligrams in the previous 24 hours, a total of 15. When we add the baseline of the PRN, then we arrive at a dose of 25 milligrams, and that becomes the new baseline for the following 24 hours. And of course, we must remember to adjust the PRN dose accordingly. So in this instance, a convenient dose is set at 5 milligrams. If you have patients who develop opiate toxicity on morphine, this will typically manifest as myoclonus in this situation, and or those who have renal impairment, fentanyl is a suitable alternative. The starting dose might be in the order of 200 micrograms by continuous infusion for 24 hours, and a PRN dose of 50 micrograms. In the instance referenced in this slide, you see that the patient required 6 doses of 50, bringing it to a total 24-hour PRN use of 300 micrograms. So we simply marry that to the baseline of 200, and we have a new baseline dose of 500 for the following 24 hours, and we adjust the PRN dose then accordingly, and again that works out at 100 micrograms in this instance. Now, it is not strictly necessary to administer drugs by continuous subcutaneous infusion at the end of life. If infusion devices are not available, or perhaps they are available but people are not confident in their use, we can simply administer the 24-hour dose of whatever medication is required, an opiate, a sedative, whatever, in equal amounts every 4 hours. And we can continue to use PRN meds in the normal way. And as I referenced earlier, intranasal fentanyl starting at a dose of 50 micrograms is helpful in circumstances where we don't have ready access to a healthcare professional. Anxiolytic and sedative medications are useful at end of life, particularly to manage troublesome dyspnea, which is not reversible, terminal agitation, and delirium. And in this regard, the benzodiazepine midazolam is perhaps the one that's used most frequently. A typical starting dose of midazolam might be 10 or 20 milligrams by continuous subcutaneous infusion, and the PRN dose could be set at 2.5 to 5 milligrams every 2 to 4 hours. And again, just like we did with the opiates, the following day's dose will be informed by the previous day's requirements in terms of baseline and PRN use. If patients have a history of benzodiazepine use or dependence, they may need to use higher starting doses. And again, as with opioids, we observe a large variation in dose required for individual patients in the range of 10 milligrams for 24 hours up to maybe 100 milligrams for 24 hours or even more. Again, we are guided by the principle of individual titration, and the patient's overall level of comfort will determine the dose that they will require. Additionally to opioids and benzodiazepines, we use anxiolytic and sedative medication at the end of life. Again, these are helpful in dyspnea and terminal agitation and delirium. And the two that I reference here are the phenothiazine, levomethomazine, and haloperidol. And the doses are listed as you see here. Levomethomazine, perhaps 25 to 50 milligrams over 24 hours. It may be necessary to titrate that up to achieve the best possible response, and the appropriate PRN dose is then again set at between a quarter and 1/6 of the 24-hour dose. And similarly, the same principle applies for haloperidol. And both of these drugs, in addition to their sedative effects, have useful antiemetic effects. So it may be necessary or desirable indeed to exploit more than one effect from the same medication. Levomethomazine is likely, or at least more likely than others, to cause local skin reactions. So just take care to watch the site of infusion, and it may need to be changed more frequently than would otherwise be the case. One symptom that causes great distress to family and staff is the troublesome, noisy upper airway secretions known as the death rattle. And in this regard, any medication must be introduced early to prevent an excessive buildup of secretions. So it's a prophylactic approach. And using any of the agents that we have available to us, we will get a good response, a satisfactory response, in perhaps somewhere between 1/3 and 2/3 of cases. So there are a cohort of patients who will continue to experience troublesome oropharyngeal upper airway secretions despite our best efforts and timely interventions. Again, families need to be alerted that this is a possibility, explain the mechanism to them, and reassure them as best we can. These patients will often benefit from careful positioning, and if the secretions are relatively high, it may be possible to remove some by gentle suctioning. We don't generally recommend deep suctioning in this instance. Please be careful to check for fluid overload. Again, avoid excess IV fluid use. And if a person is fluid overloaded, it's reasonable to give them a trial of a diuretic. But please make sure that they are catheterized in this situation, because we don't want to precipitate an acute retention, particularly with the co-administration of antimuscarinic agents. Note that antimuscarinics are of limited value in cardiac failure or pneumonia. And note also that diuretics are of limited value unless the underlying problem relates to fluid overload, pulmonary edema, and or cardiac failure. The secretions that we are dealing with are mostly related to saliva. We produce between 1 and 1.5 liters of saliva every day, and that needs to go someplace. We also, of course, have bronchial secretions, which will increase if there's inflammation or infection. Pulmonary edema may be another contributing factor, and gastric reflux. So the anti-secretory agents that we use are designed to prevent the buildup of troublesome oropharyngeal secretions, and we may use them, of course, for more than one indication, as I'll explain in a moment. I've chosen these three drugs. These are perhaps the one most commonly used in palliative care practice. There is no drug that is inherently better than all of the others, so the choice of agent generally prefers on prescriber preference. Glycopyrronium does not readily cross biological membranes. It's administered in a stat dose of 200 to 400 micrograms and infused over 24 hours at a rate that varies between 600 up to 1600 micrograms, most commonly 1200 micrograms over 24 hours. Hyoscine butyl bromide, known as Buscopan, does not cross the blood-brain barrier. It's administered in a dose of 20 milligrams stat and infused at a rate of 40 up to 80, perhaps even up to 120 milligrams subcutaneously over 24 hours. And thirdly, there's hyoscine hydrobromide. This differs from the others in that it does cross the blood-brain barrier, and it has consequent sedative and antiemetic properties, which may in this instance be desirable. A 400 microgram stat or an infusion of somewhere between 1200 up to 2400. Rarely we've gone as high as 3600 by continuous subcutaneous infusion over 24 hours. As referenced, there's no evidence that any one of these drugs is any better than another. Using whichever drug you might choose, you'll probably get a response in between 1/3 and 2/3 of cases, and you will improve your response rate by making sure that you introduce these drugs once a diagnosis of dying is made. In terms of opioid dose ratios and conversions, again, just to give you some guidance, typically converting from oral to subcutaneous, it's 50%. From oral to intravenous, it's 33%. So what that looks like is that morphine 60 milligrams over 24 hours by mouth, that would equate to 30 milligrams subcutaneously over 24 hours or 20 milligrams intravenously over 24 hours. A proportion of the COVID-19 positive patients will be deemed suitable for ventilatory support. In this regard, I note that the decision to offer ventilatory support rests with the senior responsible clinician. Equally, the decision to withdraw ventilatory support rests with the senior responsible clinician. The decision will be informed with due regard to input from other clinicians and healthcare professionals, and family members will also have a view they may wish to express. And while family opinion is helpful in informing the decision to proceed and or to discontinue with ventilatory support, it is important to note that the family is not the decision maker. So while we need to engage well with the family, we need to understand the patient's previously stated wishes or if they have an advanced care plan, but we must take great care not to cause the family member to feel that they have somehow authorized or approved the death of their loved one. This places an unfair, unreasonable, and inappropriate burden on their shoulders. These are medical decisions and they must be made by the senior responsible clinician. By way of reassurance, can I just say that withdrawing ventilatory support at the point of medical futility is a medically, morally, and ethically justified act to facilitate a natural death and should not be equated with physician-assisted suicide or euthanasia. Family and staff members need support, explanation, and reassurances to appreciate that we have reached the point of medical futility. Our objectives, our focus shifts therefore to ensuring that the patient is as comfortable as they can possibly be. We wish to avoid the distress associated with inappropriate prolongation of dying and the discomfort associated with endotracheal intubation and all that goes with it. Hopefully this will help also to reduce bereavement morbidity. Once the decision is made to withdraw ventilatory support, staff and family members should be fully briefed, and the ventilatory support should be discontinued in a timely fashion in the setting where the patient is currently receiving care. It is never possible to predict precisely how long a patient may survive thereafter, but if death does not occur within a reasonable time frame, it may be necessary to transfer the patient to a less acute setting in order to free up a valuable ICU resource. When withdrawing ventilatory support, the focus, as always, is on patient comfort. These patients generally will be helped by the administration of IV medication preemptively, typically a dose of morphine, say 2.5 to 5 milligrams, combined with midazolam 2.5 to 5 milligrams, administered over 5 to 10 minutes before the planned withdrawal, recognizing, of course, that higher doses may be required in some patients. And these may be repeated through the intravenous route as necessary, depending upon the clinical response. An antimuscarinic such as hyoscine hydrobromide, butyl bromide, or glycopyrronium should be administered subcutaneously 1 to 2 hours before the planned withdrawal if the patient is not already receiving an antimuscarinic. And it would be helpful at this time also to set up a continuous subcutaneous infusion to include not just the antimuscarinic, but also an appropriate dose of morphine and midazolam, recognizing, as mentioned previously, that fentanyl is preferred to morphine in patients with significant renal compromise. So, for example, if we have a ventilated patient who is currently receiving morphine 5 and midazolam 5 milligrams intravenously per hour, 1 to 2 hours before the planned withdrawal, I think it would be helpful to give hyoscine hydrobromide 400 or one of the other alternatives, and to set up a continuous infusion with hyoscine hydrobromide 2.4 or alternative. And just a few minutes then before the withdrawal, I'd give a bolus of morphine 5 and midazolam 5 over 1 to 2 minutes, and this can be repeated as necessary depending on the clinical need and clinical response. If the patient is staying in the ICU setting, you can continue a baseline IV infusion using the morphine and midazolam. But if transferring to a ward setting, it may be more practical to convert to a continuous subcutaneous infusion of morphine, midazolam, and hyoscine. The typical doses of subcutaneous medications used at the end of life I've summarized here. So for morphine, that might be in the order of 30 to 60 milligrams over 24 hours. For fentanyl, it may be somewhere between 400 to 1200 micrograms over 24 hours. Hyoscine hydrobromide 2.4, midazolam maybe 20 to 60. But bear in mind, these are guidelines, and the dose required for an individual patient must be assessed on a case-by-case basis. Should you require further advice and information, please feel free to contact the palliative care team in your own hospital, or contact the doctor on call at the Regional Specialist Palliative Care Unit, which in Cork is based at Marymount in Curraheen. If you have access to the palliative care formulary, it contains a lot of detailed information about the drugs and the doses that I've discussed throughout this presentation. And also more detailed information may be found on the website of palliativecareguidelines.scot.nhs.uk for those who would like further background and more detailed information. I thank you for joining this presentation. I wish you well, and please be assured that if you have any questions or concerns regarding end-of-life prescribing or related management, please feel free to contact your local specialist palliative care service. Thank you.